Okay, this is Carrie Levy. I've been given the go ahead to start. Is the sound okay, Hillary?
It does, yes.
Okay, it sounds very echoey on my end, so thank you. So thank you all for coming. I'm honored to have the opportunity today to introduce Dr. Hillary Lum. She's been a dear friend, an inspiration, and a colleague for the past decade. She's currently an associate professor of medicine in the Division of Geriatric Medicine at the University of Colorado. And in addition to her clinical work as a geriatrician and palliative medicine physician, her career goal is focused on helping older adults with serious illness receive care that aligns with their care preferences. Her research involves testing innovative models and implementation strategies to improve advanced care planning and quality of life. And her approaches have been quite varied, ranging from telehealth to community partnerships to population health-based approaches. She received her undergraduate training at Northwestern University and her MD and PhD from the University of Wisconsin. Interestingly, her PhD is in cell and molecular biology, which will probably not make it into the presentation today. She then completed her internship and residency at the University of Pittsburgh Medical Center. And we're fortunate that she then chose to come to the University of Colorado for her fellowship training in geriatrics and hospice and palliative medicine. She also participated in a health and aging policy fellowship program here in Colorado. She is currently triple boarded in internal medicine, geriatrics, and hospice and palliative medicine. She recently completed a career development award in aging, and she was funded by the prestigious Beeson Grant from the NIA Hartford Foundation. These go to people who are seen as emerging leaders in the field of aging research, and she is clearly that. She has is actively participating in 11 grants funded by the NIA and VA. And they range from pragmatic interventions for people living with dementia to group visits for advanced care planning. And relevant to our discussion today is decision-making related to cancer prevention and treatment among those with dementia. So I also need to mention that she has 89 peer-reviewed publications, 19 here in the past year. So she's been writing quite a lot. And one of her many gifts, in addition to her writing and her research, is really building these programs and a program architect. She's built a number of different programs across the campus. And today she's going to speak about her stakeholder engagement to improve health equity in rural cancer care work. So Hillary, with that, I will turn it over to you.
Thank you so much, Carrie. Thank you for all joining both here in our auditorium and on Zoom, and those who may be watching on the recording. It is really great to be able to share. It feels in a way to be coming home to a cancer center. I did do my PhD in cell and molecular biology, but particularly in tumor immunology. I studied CD40 activation of macrophages as part of the innate immune system against cancer. So this is full circle, and for any of you who are pre-doctoral students, PhD students, who are trying to think about how can your work and the research methods that you are learning be applied in different ways across the T0 to T4 spectrum, they certainly can be. And I've loved the opportunities for team science and collaboration, which this certainly represents, to really come to fruition or even be just a really exciting journey. So we are going to talk about stakeholder engagement to reduce health inequities in rural cancer care. I am a mentored member in the Cancer Prevention and Control Program, and so as a mentored member, I'm really indebted, and you'll see in this presentation, trying to highlight some of the work and collaboration we have through the P30 supplement on aging and cancer, the Community Outreach and Engagement Core, the P50, Colorado Implementation Science for Cancer Control, which I'll tell you more about, the Rural Cancer Advisory Board, and the CCTSI Dissemination Core. So much thanks to many partners, and I'm going to highlight parts of how they have been supportive of our work in stakeholder engagement. So here's the outline for today. We'll talk about the problem in rural cancer disparities, 2 rural Colorado examples that we're engaged in, our commitment to stakeholder engagement here at the Cancer Center and some resources that hopefully you can make use of, and the road forward in terms of tangible research methods that you might integrate into your projects. So beginning with where we are in terms of persistent health disparities plaguing rural populations. This is not specific to cancer, though certainly these disparities are evident in cancer, as well as cardiovascular disease and drug-related injuries. The individuals who live in rural settings are more likely to have low incomes, to have no more than a high school education, to be unemployed, and to be uninsured. So this is broadly what the US looks like today in terms of rural and frontier health. Focusing in on rural cancer mortality disparities, you may be familiar with the Healthy People 2020 objective of decreasing cancer mortality. And in fact, as of 2015, that has been met for our metropolitan communities. However, we continue to see the lag for rural communities being left behind. There are still 180 cancer deaths per 100,000. So this is what we need to be addressing broadly, and I'm going to walk us through more specific evidence. So thanks to Dr. Stutz and support from the University of Colorado Cancer Center's Population Health Shared Resource in developing these age-adjusted lung cancer incidence and lung cancer mortality maps here in Colorado, looking at our different counties. So I know that it's small, but there on the left side in blue, you can see that darker blue indicates a higher incidence of lung cancer, and that is predominantly notable in some of our rural and frontier counties. Similarly, we can also see the darkest red in terms of lung cancer mortality, especially in northwest Colorado counties, northeast, southeast as well. So nationally, several different committees have really highlighted this issue. We can be motivated by a public health call to action, specifically thinking about the National Advisory Committee on Rural Health and Human Services. In 2019, some of the policy recommendations are listed here to think about how we can implement and pull in the same direction to improve cancer care, to reduce the disparities. And some of these I'll highlight. Number 2, increase funding for the National Cancer Institute's Rural Cancer Control Program and related partnerships. In fact, for those of you who follow different NOCs and other RFAs that are announced, there is increasingly an opportunity to specifically apply for grants focusing on rural health disparities, as well as a need for education, a need for reimbursement codes to align to support care coordination, and ongoing assessment of rural and urban disparities. So I want to share with us a little bit more about what we know here in Colorado. 74% of our counties are rural and frontier. So those are listed in the light blue and dark blue. Hopefully that's something you're well aware of, but it always surprises me actually how rural and frontier Colorado is. Here are some of the data from some of our ongoing surveys, specifically from the Behavioral Risk Factor Surveillance Survey that happens periodically. And you can see the lifetime colorectal endoscopy rates for the purpose of cancer screening, colon cancer screening. So ever had colorectal endoscopy, and you can see especially in the San Luis Valley, Alamosa, southeast Colorado, we have fewer, lower rates of endoscopy. Mammography in the past 2 years, the rate of that is also clear that there's a disparity in screening rates, despite a lot of attention to this. So we still need to work on this. And here's data related to lung cancer screening sites. So if we think about, well, where are the healthcare facilities that have capacity to do low-dose CT for the purpose of lung cancer screening? Well, you can see they're really concentrated along the I-25 corridor and then otherwise scattered. And really, as we look at the lightest blue for frontier counties, maybe there are 2 in counties that are identified as frontier in terms of screening opportunities. So distance to travel is noted as one barrier and reason for rural health disparities. But as we go through this talk, we're going to see the importance of stakeholder engagement because it's certainly a complex issue that feeds into our health disparities. overall, how does Colorado rank in terms of uptake of lung cancer screening? And I think you'll see here in the orange, we are perhaps 10th lowest, and certainly lower than the US average, which is at 5%, although admittedly that is still extremely low. Also, this figure demonstrates that the Northeast, the darkest gray, you are more likely to have lung cancer screening uptake compared to the lightest bars, the West, the Mountain West, more rural and frontier states. So a lot has been written about the need and opportunity to close the rural cancer gap. I'm going to highlight this State of the Science event that was hosted by ASCO from April 2019. So this is a conference paper that comes out of that gathering of experts. And I'll highlight that local problems require local solutions that are based on community needs, available resources, and trusting and collaborative partnerships. And the examples that are in this brief recognize also the values and capacity that our academic cancer centers can bring to this discussion, the resources that can be leveraged towards local partnerships. So as we think about now, what can we do? Here's again a map you're probably familiar with. Where are our NCI designated cancer centers? And then how do we act locally? I think also, how do we act if we are doing T0 science all the way across to T4 science? As I mentioned in my intro, I did my PhD in T0 basic science research, and I think I am where I am today through attending sessions like this to think about, even though it may sound like a lot of jargon if this is not your field, what are the different ways that we can be operating in partnership and in collaboration and team science with colleagues and partners and community members who may be bringing up T3 or T4 comments and questions and suggestions, even as I'm doing research that's at this point T0 basic science research. Those of us who, of course, write proposals need to make that case that this matters in the real world. It matters to a lot of different stakeholders. And I also think that increasingly we need to recognize the importance of health equity in the relevance that and the rationale and the support we make for why our science matters, including addressing health disparities. Perhaps you've seen this figure before. I think it's a very good overview of the continuum of community engagement that can happen. For any that have applied to PCORI, the Patient Centers Outcome Research Institute, you may be quite familiar with the different ways that individuals as community members or different stakeholders can be part of partnering with researchers. You may have individuals as the researcher, you may have individuals involved at an outreach, in an outreach capacity, consultative. They may be involved as collaborators, or there may even be shared leadership in your different projects. And I've been fortunate to have different levels depending on the project and depending on the funding and depending on the timeline. So there are a lot of different factors that help us to decide what level of stakeholder engagement can we have capacity to follow through on. So I wanted to also highlight some additional tangible aspects that then I hope to show us some examples of in terms of how might we align public health, primary care. As a geriatrician, I practice in a primary care setting and community efforts to improve rural cancer control. So one example, if you are primarily a secondary analysis, secondary data set researcher, you might utilize existing data and develop new methods for working with small sample sizes. You might, secondly, prioritize efforts to evaluate, adapt, and expand evidence-based interventions to rural areas using multidisciplinary research strengths. So this might be if you are working on an implementation science-oriented project, or even if you are in sort of a T2, translating to clinical care perspective, you might still try to think about how could we have a multidisciplinary perspective that allows us to cross some of these barriers, overcome challenges. Third approach might be to weigh the pros and cons of rural definitions and consider the interaction of geography with individual and regional factors. I think especially if you've been thinking about the social determinants of health and their influence on your research question, there's a lot in terms of how do we define rural. I'm not an expert in this, but it's helpful to realize that that also is a evolving field. And then fourth, you might utilize an equity-based participatory implementation science approach, a lot of jargon there, to improve and align research and quality improvement efforts. And I'm gonna give an example of one framework that I've been learning more about, which is here. So this is by Woodward et al., a health equity implementation framework. This is a determinants framework that helps us to explain factors that are relevant to implementation and disparities in healthcare. This is not specifically designed for rural, but I think it helps as a lens in which we can think about in the center there is the clinical encounter. And then you have multiple recipients and you have patient factors, other recipients, provider factors, as well as the characteristics of the innovation. Those all occur within a local context. And often for our T2 research, we're thinking very specifically about just the bedside or just that one clinic visit. But actually it happens in the context of perhaps an oncology team, in the context of community-based clinics, which may or may not have all of the different team members and resources that a more high resource setting and context may have. And then that's healthcare setting still sits within a larger societal context. And so we could think about economies, physical structures, socio-political forces that all influence how actually an intervention benefits or does not benefit the person who it's intended to affect. So that's a background on a pathway through our rural health disparities specific to cancer, and even some suggestions on how we might try to take some approaches and apply them to some of our cancer-related questions. So I'm going to tell us about a first example related to the P50, which is the Colorado Implementation Science Center in Cancer Control, led by Dr. Glasgow and others. So just to back up a little bit, there are 7 funded transdisciplinary collaborative research centers, which are sort of collectively known as ISC3s. It's a network that seeks to advance the implementation of evidence-based cancer interventions. I'll highlight here that one bullet is building implementation laboratories in diverse clinical and community settings. Here's a list of the 7 different centers. Here at University of Colorado, our focus, our theme is pragmatic approaches to cancer prevention and control in rural primary care, which is probably no surprise given where we are and given the strengths that we have here at University of Colorado, especially through the Department of Family Medicine and our practice-based research networks, as well as our connection to the National Research Network, which is part of the American Academy of Family Practice. So there we are, located in the Mountain West. And so with our positioning and with our focus on cancer prevention and control, in particular, we also have a focus on shared decision-making in cancer screening. So I'm showing here on this slide the overall themes of our particular Cancer Center, Implementation Science Center. We're trying to focus on multiple stakeholder perspectives on values and costs that drive decision-making, thinking about multifaceted and multi-level context and related adaptations to evidence-based interventions. And then we're also thinking about reach, implementation, and sustainability in rural primary care. So now to take a step back to sort of introduce my involvement in this Colorado ISC3. I'm a geriatrician. I care about individuals with serious illness, and in particular, caring about those with cognitive impairment and their family care partners. So this was an opportunity to ask, because actually there's very little in the literature and very little, as we're learning in practice, known about the perspectives of persons with early dementia, their care partners, and the primary care team in a rural context related to cancer screening shared decision making, including how do individuals discuss risks, benefits, and burdens of cancer screening in the context of dementia? How does shared decision making conversations happen? Are there any barriers to screening and dementia care in rural areas? And then how might we adapt to help assist primary care team members to meet the needs of persons living with dementia? So an Alzheimer's disease supplement is a one-year supplement to, in this case, the P50 Cancer Center, and we are conducting a qualitative study to address this question. So our setting is 4 rural practices selected from the High Plains Research Network with Dr. Tamara Ozer as the director, as well as the National Research Network. Our goal is to interview people who have different perspectives. So those are listed here. We want to have multiple stakeholder perspectives. And I've shown again, just a part of the health equity implementation framework so that you can sort of see that as we're learning from these individuals, as we interview them, I'm able to, we're doing our qualitative analysis to sort of understand, are there prevailing beliefs, common preferences, aspects of culture related to living in their rural context or related to their family perspectives that are influencing how cancer screening decision-making happens. So I have 2 slides of emerging findings. Theme 1. These are from, at this point, 11 provider interviews, which can include some of the practice staff. So we have not yet analyzed the patient or the care partner interviews. So in a first theme, providers report engaging patients regardless of dementia severity and their care partners in discussions of cancer screening. So they describe that they are doing it and that they don't specifically exclude individuals because of known cognitive impairment. A second theme, providers adapt. They adapted the discussion of risks and benefits of cancer screening to the level of patient understanding, and they gave us some tangible examples of how they modified their cancer screening discussions. Then also, as a subset of how they adapted, they described sort of an informal but specific shift of decision-making to the care partner over time as patients lost decision-making capacity. And some of our deeper dive of the evaluation is going to be, how did they navigate that change in shifting to the decision maker being the care partner instead of the person with cognitive impairment? In terms of additional themes, so theme 3, as the patient loses the ability or capacity to make informed decisions, providers noted significant considerations to the care partner's perspective and values of the patient's quality of life. This is very good to hear, that care partners are really trying to share their perspectives. And that, of course, is going to be related to the culture, both of their individual family life, perhaps of what they know of the person, and we'll be interested to see if there are aspects of paternalism or stigma or sort of less attentiveness even to specifically talking about dementia in these rural communities. Theme 4, patients and care partners who have had personal or family experiences with cancer tended to continue to desire cancer screening, and shared decision making was not as prevalent. So I think this was an interesting theme to see, because of the longitudinal relationships that many of these providers have with their patients, often caring for the whole family over a number of years. They would hear that a person or the care partner quickly noted, well, you know, we have this experience of cancer in our family. And so even if potentially a cancer screening might warrant what I might judge to be more of a decision about risks, benefits, and burdens of cancer, there was still an anchor to, well, so-and-so had cancer in our family, so we really want to make sure that we screen for it. Theme 5, some providers noted a culture of distrust of the medical establishment in rural settings, and this is very much about sociopolitical forces. There were comments about, well, maybe that test is just being done so that the doctor can be reimbursed, be paid for it. So that's a whirlwind perspective of one example of how we're engaging stakeholders, in this case formally through an interview process, to really try to understand multi-level perspectives. I'm now going to shift to a second supplement. This is to the P30, and this is specific to cancer and aging, and you can see our collaborators here. So to give you just a perspective on this supplement, the overall goals are to build infrastructure to promote scientific exchange related to cancer and aging. I'm going to focus on our second and third goals: to identify geriatric assessment tools, to extend evidence-based practice to community-based oncology and rural primary care practices. Then we'd also like to enhance the capacity for patient-centered data collection in clinical research on cancer and aging. And I appreciate this because one aspect of stakeholder engagement is thinking about what's meaningful to the person. And one way we can know what's meaningful is to ask them, but then we also want to identify what are pragmatic, practical ways we could actually assess and learn from people what their experience is on patient-reported outcomes. So here's another view of our aims. I'm going to focus first on how we identified geriatric assessment tools here in Colorado. The purpose is to really want to do an assessment that looks perhaps more at the whole person and their function rather than anchoring just on someone's age. So I have 2 slides to describe our methods. So first, in terms of engagement, we conducted 4 focus groups with different types of providers. 2 groups were primary care providers, 2 were oncology, and you can see in the graph, we asked them to review 4 different types of geriatric assessments. These are called the G8, VES 13, thinking about the annual Medicare wellness visit, then also a functional assessment with activities of daily living, instrumental activities of daily living. And in green, you see where individuals said positive rating, like this is a very reasonable assessment. I could see integrating it into practice. And then red was negative, blue was no preference. So visually, we see that the G8 was the most positively rated, as well as an assessment of functional status with the ADLs. So from this first step of engagement, we then went forward with the G8. One aspect of stakeholder engagement can include engaging your operational partners. So as a team, Dr. Sherbinel has led working with Lisa Schilling and others within EPIC to think about whether we could develop a patient questionnaire that could be sort of delivered to people prior to a clinic visit to ask them about the G8. Simultaneously, we also continued to talk with external providers, including in a practice-based research network called PeachNet, which is primarily located on the Western Slope and led by Dr. Netterveld. So wanting to think about what would be involved in actually using the G8 in clinical practice or part as an electronic health record integration. So here's just a map of the distribution of individuals who participated in the focus group. Again, we really made effort to try to do as well as we could. Blue are primary care providers and their distribution across the state, and orange are oncology community-based providers. So then after we did some operational engagement, a next step was a brief pilot. So we were able, through PeachNet and Dr. Netterveld's leadership, to engage 7 community providers, a mix of primary care as well as oncologists, who trialed integrating the G8 as part of their routine clinic visits. We asked them to do it for 3 weeks for individuals over 65, and a number of the providers really found this to be possible. They, in brief interviews afterwards, told us that they often were able to do it in 40 to 60 patients. They gave us good feedback that the G8 questions were answerable by the patient, and then often led to brief follow-up that the oncologist or the primary care provider felt was able to be integrated into their clinic visit. They felt that the information was helpful. So that was positive, and now we're planning next steps of thinking through how can we do a validation of use of the G8 in a broader group of community clinics. So simultaneously, as we're trying to think about, well, how could the G8 be asked as part of the electronic health record? Inherent in that is that it would be self-report, because someone might get it through Epic's patient portal, the My Health Connection app, and therefore it needs to be patient report. So another aspect of stakeholder engagement has been to get input from something we recently established called the Rural Cancer Advisory Board. This name actually comes from the people who make up this committee. I'll tell you a bit more about it next, but interestingly, they gave us input on the wording of the questions to make sure that it's usable. As an example, the G8 asks, is your patient having any neuropsychiatric or depressive symptoms? So that's not at all sort of patient-friendly, person-friendly, and the Rural Cancer Advisory Board is able to call that out to us and suggest different wording to still get at a similar or the same concept. I've noted here that as we work also with Epic, Epic has said that, well, yes, we could use 4 of the questions from the G8 that could be administered through the patient portal, but then the other 4, like age, body mass index, and a few others, could actually just be extracted from Epic. So it's interesting that as this evolves with true stakeholder engagement, Epic would be interested in sort of doing a G4 that goes to the patient plus 4 that comes from the electronic health record. So we'll see where we end up as we continue to work with our operational partners to see how we might be able to build something that could be administered to patients prior to their visit so that they have an opportunity to highlight how their life is going from a geriatric assessment perspective. And then also we recognize the need to validate a self-report compared to clinic collected. And we have a grant proposal under review to evaluate this. So now I'm going to shift to just more broadly. I told you about 2 Colorado examples, and now I'd love for you to be thinking through how might what I'm working on be able to be something that I could get input from existing resources here at University of Colorado's Cancer Center specific to stakeholder engagement. And I'm going to highlight the Community Outreach and Engagement Core with many thanks to Dr. Barrero and others for her leadership and the whole team. So the Community Outreach and Engagement Core's aims are listed here. They really want to help each of us as Cancer Center members to have up-to-date data on how we're doing in Colorado, where our disparities are, both from a rural perspective as well as by race, by age, and other demographics. Secondly, they want to enhance and disseminate the center's research for impact, and they want to be a longitudinal opportunity for engaging communities in science, education, and advocacy. So I really think that their mission and vision is so important for us to remember, and we can make use of it specifically for research, but also if you are doing community outreach, if you are doing community education, I think there are many opportunities for partnership. You don't need to feel that you need to do it alone. This is a overview of who's involved, and so hopefully you know some of these individuals. They're very responsive by email, so I really encourage you to reach out. One of the core aspects of the COE is that they have this ongoing community advisory council. I've had the privilege of presenting and learning more about the members of this council. You can see all of the different organizations that are represented by really thoughtful people who care a lot about how to improve cancer care and cancer experience here in Colorado through our Cancer Center. And one notable thing about this council is that they wear a lot of different hats. Some have had personal experience with cancer. and they are members of organizations. So we still saw that there was a gap, and that then is where I'll tell you more about our Rural Cancer Advisory Board, which is community member specific. But in terms of the CAC, they have every other month meetings, I believe, and they are a great opportunity to learn more. And so please reach out to Sarah Roberts and others to find out about their meetings. Here's just an overview, which I'm sure is rapidly changing, of current COE projects. Hopefully you recognize some of these. And I think as you think about where might your research sort of align with something that is happening that the COE is working on, they are very interested in collaboration. You can see that our P30 Aging and Cancer Research Project is on here as well. One of the resources that the COE maintains was released in January of this year, and I think this is high yield and very helpful. This is a virtual cancer resources map, which makes a point of really trying to have up-to-date examples of resources that exist across our state of a lot of different types. So a resource to look into. I'm now going to transition to specifically the Rural Cancer Advisory Board. We launched this earlier this year, May 2021, and while some stakeholder engagement committees have struggled in the time of COVID because there's needed to be a transition from meeting in person to figuring out how to meet virtually. For this group, because you can see the distribution across the state, we are committed to meeting virtually, though we do certainly hope that there might be like an annual gathering, an opportunity to get together that people would travel for. So this is a start. We are really excited to have 10 individuals. They all happen to be women at this point in rural communities. You can see the age range and ethnic background and also vocational background here. There are individuals who are cancer survivors, individuals who have close family members who have cancer, and individuals actually who don't have specific experience with cancer and yet can speak to some of those cultural aspects of what healthcare and engagement in cancer treatment or care and engagement in research, how that's viewed in their local community setting. So this is a resource available to you. Please feel free to reach out to me. We meet every other month. You can see our upcoming dates. As I alluded to, on July 21st, Dr. Liz Kessler came and presented on our Aging and Cancer question about the G8 screening tool. And then most recently in September, Dr. Stutz and Aaron Hirsch came and asked about a lung cancer screening approach. So you can see an example of the agenda where we really try to build community and knowledge among the board members so that they have capacity to be highly engaged research partners. And then there's a specific presentation. There's a lot of time for discussion about the research project, and I'll give you an example here. So from Dr. Stutz and Aaron Hirsch, they desired input on intervention design focused on engaging rural residents regarding a new approach to lung cancer screening. Their goals were listed here. They really wanted to just understand baseline awareness of lung cancer screening, then identify questions and concerns that the rural residents had. And then they wanted insight into messaging, imagery, intervention approaches that will align with rural perspectives. And here's one slide that summarizes their takeaways from that engagement meeting. So they concluded from listening to this discussion that there was limited or non-existent awareness of lung cancer screening, that procedure experience, cost, and benefit are very important in terms of information that people want. They want to know, what is it like to have a low-dose CT, and even what is a low-dose CT. Third, they heard the important emphasis on trust, reputation, and legitimacy of the healthcare provider, the healthcare clinic, the healthcare system, and that's very critical from a rural perspective. One tangible way that that can be increased is through collaboration with local clinicians, and also the importance of health departments. I think in an urban setting, the actions of the health department may not at all be known or tangible. In a rural community, it's very different. The health department may be the steadiest source of information, and that's one of the things that was shared at the RCAB meeting. And then imagery should portray benefit. I think we can all resonate with this in commercials, where often commercials show very positive imagery rather than people sick or struggling. And their next steps are listed here. So projects can come to our Rural Cancer Advisory Board at any stage of the development of their project, whether it's at the very beginning in terms of what questions are important to ask, all the way to how can I help with recruitment, how might that be more viable in a rural community, to how could we share results to your community. We've completed this study and we want to make sure that it's shared out. And so now I want to end with some resources of how you might tangibly, thinking about research methods, engage stakeholders as part of your project. And here, this is in partnership with Dr. Bethany Kwan, who leads the Dissemination and Implementation Core within our CCTSI. So I probably should have started with this at the beginning, and yet I'll put it here because maybe you have been sort of skeptical about, well, it doesn't matter to do stakeholder engagement. And, you know, I've asked a few questions. Isn't that engaging stakeholders? So a rigorous definition of stakeholder engagement is that it's bidirectional, longitudinal relationship between stakeholders and researchers that informs decision-making about research prioritization, conduct, and dissemination. It involves multiple stakeholder types to ensure the research is feasible, scientifically rigorous, and relevant. Certainly some of your proposals may be strengthened by having robust stakeholder engagement, which might be evidenced through letters of support, through payment of individuals for ongoing relationship as partners rather than as research subjects, and even a commitment to dissemination where presentations and publications are co-authored. I want to share a tangible resource. This is dicemethods.org. Although it doesn't have CU in the name, this is a product of our CCTSI. I encourage you to look it up now. It has a helpful overview of what this stakeholder engagement navigator is, and then it's very tangible in terms of prompting you to think about where is your research question, how much money do you have, how much time do you have, and then giving examples of different types of stakeholder approaches and methods. This engagement navigator also helps you think through who might the different stakeholders be that you hope to engage. And I present this here just as an overview, the 7 Ps published by Thomas Concannon et al. That sort of is a rubric for helping us remember many different types of stakeholders. There are probably others than these, but you'll notice that principal investigators is there listed at the bottom. As I do stakeholder engagement, I have to continually remind myself, where is the power dynamic? Who's making the decisions? Where is my agenda among the many stakeholders that I hope to have be at the table? So here are some examples of stakeholder engagement approaches. You might think about this as a conceptual model or an organizing framework. So this is sort of the big picture approach of how you intend to involve stakeholders. And then there are also methods, and there are a number of them listed here. You might be familiar with some like boot camp translation. That happens a lot here and is really something that we are expert in within the Department of Family Medicine, of how can we create messages about evidence-based interventions or results in a way that resonates with communities. And so community members participate in this boot camp process of really working on messages to develop lots of different media of different types that will resonate with communities. You might be familiar with I-Cores. That's also something offered by our CCTSI to think about your user as a consumer of your product, your research findings or intervention, and how can you make sure that you're communicating the value of it. So in terms of partnering with stakeholders, there are a lot of key principles that are listed here that I think are important to just reflect and be intentional about. There could be a whole talk on how you capture and collate and integrate data from each of these processes, and there are certainly strong resources here on campus, including that the dissemination and implementation core, as well as within Accords, the D&I group, are really happy to provide consultative help on your question about stakeholder engagement that you might have. So with that, I will transition to any questions that anyone has. But again, I want to give special thanks to many different entities, research groups, resources here on campus, wonderful collaborators. Teamwork really makes the dream work. So thank you. I'll open it up, any questions in the room, and then we can see if there are any on Zoom. Any questions on Zoom?
So Hillary, we had a couple of resources posted. Is the sound okay?
Yes, I can't see the chat, so I appreciate you sharing the chat.
So there were just some postings of the Colorado Cancer Coalition.org cancer map, if folks want that as a reference. I'm not seeing specific questions, but Russ did mention that there were several other additions to, let's see, Kathy Bradley and Jamie Stutz are key members of the ISC3. So he had added that as well. But no specific questions yet, but please go ahead and post those and we'll be happy to ask them of Dr. Lum.
I'm interested, you know, talked a lot about bi-directional feedback and working with some of the rural clinics and some of your thematic results, they're really not looking at the stage of dementia into that. How do you propose, and what are you thinking about feeding back to these kind of, to some of the rural practices about how to incorporate some shared decision making and stage of dementia into those clinical decisions?
Yeah, thank you. So I'll share the question. The question is, as we are hearing specific to shared decision making in rural primary care practices in the context of dementia, and our initial insight that, or, you know, what we're hearing from providers is that the stage of dementia is underemphasized perhaps than I might judge from a clinical trials perspective. And how can I then, in terms of bidirectional adaptations or suggestions and even guidance on what should shared decision making look like in a rural context? I appreciate this question. It's on one hand, I think there's a sort of an existential answer, which is to say, if we are really going to do stakeholder engagement where the end users are involved in the definition or the adaptation of the definition of an intervention, which in this case is shared decision making, in their context, we, I would say, need flexibility in, for instance, how Medicare reimburses for lung cancer screening shared decision making. So I think there's one answer there, which is to acknowledge that the primary care provider's practice if we can hear from them that it's working from their perspective, that it's reaching their meaningful outcomes, serving the needs of their patients, then we should not, from a research perspective or a guideline perspective, overlay a definition that was never created with rural input or dementia input at the beginning. So I think that's where the science of adaptation is helpful to us, because we can identify what's the core, and then how has it been adapted to effectively meet the needs of different stakeholders. I think then specific to dementia is also a complicated question, because I also don't yet know where the gold standard actually should be. So when I wear my sort of dementia researcher hat on, especially in the context of primary care and rural primary care and community-based stigma about dementia, I think about how there's this, framework of different stages of dementia, which has its purposes for clinical trials. I think also has some purposes for clinical care. And yet it just may not be possible to implement dementia staging, as one example, rigorously. So it really helps me to think about bigger pictures of what I try to implement, and whether I can be as strict as some of maybe efficacy studies or concrete definitions would require to me, because it won't work in some community contexts. So I do think that stakeholder engagement often makes things, it reveals complexity, and it takes time.
Yeah, and Hillary, we have a question from Dr. Juan in the chat related to the spectrum of cancer prevention and control in stakeholder engagement. What are some examples of the dynamics, which you were just alluding to, of stakeholder engagement you envision as we move along the continuum of cancer care for rural residents?
Say that last part again, Carrie.
Can you provide some examples of stakeholder engagement you envision across the continuum of cancer care for rural residents?
Yes, thank you. If I'm understanding the question, the two examples that I'm currently involved with are on the end of the beginning, perhaps, spectrum of cancer prevention, cancer screening, and then there's maybe also the question of how could we involve stakeholders across a continuum of care, including survivorship and including treatment, and there I think, and into palliative care and end-of-life care, and there I think of Dr. Stacy Fisher's work, where there are opportunities to engage individuals from communities in the development of interventions, and making sure that language is even too simple of a way to categorize it, but to sort of hope that interventions resonate with individuals that we're trying to reach. I think also if we think about clinical trials and engagement in cancer treatment, there's lots of brainstorming that can happen in terms of how can an efficacy trial be more inclusive and help individuals that may face barriers to travel, barriers to long assessments, perhaps health literacy barriers. And I think those aspects of cancer treatment, there's lots of opportunity to innovate and to increase resources that help individuals to participate in their cancer treatment.
Thank you. And we also have just a reminder, if you need CME credit, please email crtec@cuanschutz.edu. And Dr. Juan, thank you for your description there, Hillary.
Well, thanks so much for all of the questions and opportunity to present. Feel free to reach out to me or anyone else who's listed on any slide. We'd be happy to chat more. And this, I think, will be available if you want to share it by video or share the link. It will be on the Cancer Center website and can be shared. Thank you.